Good evening, everybody. Welcome to the Parekh Family Foundation Global Foot and Ankle Town Hall focused on sports. The Parekh Family Foundation has been around since the 2006 year, and we really were focused initially on training and educating and holding foot and ankle camps. We are dedicated to elevating the care of foot and ankle care throughout the world. When the pandemic hit and there was a global pause in the world of travel, we repivoted our attention to trying to figure out ways that we could educate and train, but do it virtually. Last year was our first global foot and ankle town hall where we had over 1,000 people attend. And that showed us that there was some success and a path forward to using virtual education to train and educate the world at the same time, and making it open and available to patients, to healthcare providers, to surgeons at the same time. So we welcome you today to the Foot and Ankle Global Town Hall focused on sports. We've got an esteemed faculty of over 100 faculty members all around the world and corporate sponsors that have come from around the globe to try to support this effort. We're going to kick this session off tonight with Joseph Park and his group talking about turf toe. I want to thank Lasso, our sponsor, for this hour. Thanks, Joe.
Thank you for the introduction. It's truly humbling, and I really I'm honored to be here and to kick off this session. So thank you to the Parekh Family Foundation. Here's our faculty today: Dr. Cooper, Dr. Jackson. Dr. Cooper's at UVA with me, Dr. Jackson's at the University of South Carolina, and Dr. White is an attending physician at Ortho Virginia in Richmond, Virginia. I have no disclosures that are pertinent for this talk. I am a team physician for UVA. The University of Virginia is in Charlottesville, which is in the central part of the state of Virginia in the United States. In case, for those of you out there who don't know, it's the home of Thomas Jefferson, who was the third president of the United States. So today we're going to talk about turf toe, and this is actually kind of pertinent, but turf toe has ended the career of many elite athletes, and this is Deion Sanders. He's been in the news lately as he's struggled with this toe for other reasons. But briefly, we're going to go through turf toe, plantar plate injuries, the anatomy, mechanism of injury, epidemiology, evaluation, management, and some case presentations. So as you all know, turf toe is typically a hyperdorsiflexion injury in severe load, especially in football, which is when we see it most commonly. The anatomy is really quite complicated, and really when you talk about the turf toe, you're really focused on the lateral and medial sesamoidophalangeal ligament. That's the connection between the sesamoid and the base of the proximal phalanx. It was first described in 1976 by Bowers and Martin. In West Virginia, they found an incidence of 5.4 injuries per football season. Rodeo et al. Looked at 80 football players in the NFL, and 45% of them sustained significant turf toe injuries during their career, and 83% of those occurred on artificial turf. Hunt et al. In 2014 looked at 5 seasons and found a 0.062 out of 1,000 athlete exposures, 0.83% of all injuries. However, this injury was most common in the skill positions: running backs, quarterbacks, and wide receivers. On clinical presentation, it's often quite dramatic. There's a lot of swelling and ecchymosis, pain with weight bearing, especially on toe off. You really have to figure out where they hurt, and often it's on the plantar aspect of that MTP. Check to see what their range of motion is. You don't want to miss a dislocation or a subluxation, so really that's important. I always do a dorsal stress test and a varus valgus stress test. Often these happen in dorsiflexion and valgus, which is, I think, the most common mechanism. And then if either it's a very severe injury or it's sort of late in the presentation, you may see that they'll have an intrinsic minus alignment where the MTP is extended and the IP is flexed. And it's because the FHB tendon, the intrinsic, is completely disrupted. I always check to make sure that they can flex down the toe, make sure FHL is intact. Rarely you can have an injury at the same time, but you don't want to miss this type of injury. Imaging, you should get weight-bearing x-rays. If you have retraction of the sesamoids on the medial more than 10 millimeters from the proximal phalanx and lateral more than 13 millimeters, it's almost 100% sensitive for a plantar plate rupture. I would say, though, that the angle of the image can be a confounding variable. When you get an imaging study, if you do look at the x-ray, you'll see often some diastasis in a bipartite sesamoid, which is a variant of the turf toe. I like to do the stress dorsiflexion x-ray you can sometimes see increased diastasis between those sesamoid fragments. Imaging studies, a bone scan, I don't think most of us would use this, but I think it's not a great test because it's common to see increased uptake in athletes. CT, you can try to help decide if it's acute or chronic. Really, I think the MRI is the gold standard. If you believe that the mechanism is severe enough, look for fracture lines, plantar plate complex. Again, look at the FHL. Look to see if the sesamoid may be avascular. Look for OCD lesions and the tear of synchondrosis for a bipartite sesamoid. The classification and management of turf toe, this is in Dr. Bob Anderson's paper. Essentially, grade 1 normal range of motion. They're able to bear weight. The X-ray is normal, and the MRI will show an intact plantar plate. Partial tear is a grade 2 of the capsule and plantar plate. This is often much more painful, but they still are able to curl the toe down. On an MRI, you'll see some high intensity partial tearing of the plantar plate. Grade 3, which I think is now more commonly treated through surgery in these high-level athletes, you'll see a complete tear of the capsule and the plantar plate. Look for associated injuries like a sesamoid fracture, diastasis of the bipartite sesamoids, as we discussed, a metatarsal and articular impaction. And again, sometimes you'll see the sesamoids migrate proximally. The X-ray, I try to get this dorsiflexion stress lateral to look at it. And on MRI, you'll see a full thickness injury through the plantar plate. Often you'll see sesamoid and chondral injuries. Here's a great stress test, and you can see above, you can see normal, it's sort of tracking with the proximal phalanx, whereas below it does not. Grade 1 and 2, these are usually treated non-operatively with taping. I try to prevent excessive dorsiflexion. You should start early range of motion and strengthening, especially the toe flexion through FHL and FHB. Return to play, I do like a carbon fiber plate or a custom orthotic with a Morton's extension. Grade 2 usually takes at least about 2 weeks before return to play. Grade 3, you can try casting and immobilization of the plantarflexion of the MTP for about 6 weeks. Surgery should be considered if you have sesamoid migration, severe injury or instability, or in a high-level skill athlete. If there's no improvement with immobilization, therapy, and taping, you can also consider operative intervention. When you have a bipartite sesamoid, repair is unpredictable. I have grafted a few with even getting the bone to heal, but the patient still really hurts. I think casting is likely the best option. In terms of the surgical repair, most people, if you were to repair medial and lateral, would use a 2-incision technique. If the collateral ligaments, especially medially, are injured, or the FHL or osteochondral defects, you should debride them or clean them as you're approaching them. And then always look for the nerves. This can be a significant debilitating injury if the nerves are injured. I've seen that in some of my referral patients. Here's a picture from the Bob Anderson paper showing the reconstruction of the plantar plate and the complex anatomy again. Post-op protocol, if you are to fix it, I keep them non-weight bearing on crutches for about 2 weeks just to protect the plantar incision, especially 4 weeks of mobilization and plantarflexion and heel weight bearing. And begin gentle active flexion of the hallux at 2 weeks post-op. I think that's really critical. You want to make sure that toe starts moving, so you have to really trust the repair and limit range of motion to neutral until about 6 weeks post-op. I try to get them to neutral at 6 weeks and then increase the range of motion by 10 degrees per week for 3 weeks. After they get to 30, I do not try to get more range of motion than that, as they just will gently loosen during sports. Again, really focus on strengthening of the flexors. Return to play can be 12 to 16 weeks. And again, carbon fiber plate, Morton's extension is a good idea. Here at UVA, we did a study with Dr. Anderson. We looked at this was an NFL study. We found that 50% risk of injury occurs at 78 degrees of anatomic MTP dorsiflexion. So we suggested that if you limit dorsiflexion to less than 56, that there would be a decreased theoretic risk of injury. And this led to Under Armour coming out with the shoe, and the NFL actually adopted this rule in terms of the shoe wear that athletes can wear. In Bob Anderson's experience, 17 out of 19 collegiate and professional athletes were able to return to their previous level of activity after direct repair of grade 3 plantar plate injuries, and suggested that maybe more aggressive treatment would be beneficial for these high-level athletes. There are several other case studies and series, but no prospective randomized trials. Smith and Waldrop in 2018 looked at 15 competitive football players for grade 3 injuries. All were able to return to football, and missed time on average was 16 and a half weeks. Range of motion was approximately 42.3 of dorsiflexion, and the AOFS Halleck score was 91.3. Pain was minimal, less than 1. Okay, so we're going to go through our case presentations. If there, Selene, if there are no questions, let's see here. So Dr. White is going to present his case presentation. I'm going to share it for him. Very good. Okay, Peter, you want to take over? I can forward the screen, okay?
Yeah, that'd be great. Can you hear me?
We got you.
Yes.
Joe, can you hear me?
Yes,
You're good?
yes,
Okay.
we can. Yep.
All right, great. Well, again, I want to echo what Dr. Parekh said. It's an honor to be presenting to everybody tonight. So thank you very much for having us, Dr. Parekh. So this is a case presentation of a surgically treated turf toe. So just a little bit about me. I went to Clemson University for my undergraduate degree, and then completed my medical school and residency down in Charleston, South Carolina, the Medical University of South Carolina. And then Dr. Parekh was actually one of my attendings in fellowship at Duke. So as Dr. Parekh talked about earlier, the mechanism of this injury is fairly common. My patient was an 18-year-old basketball player who's actually the Class II Virginia Player of the Year and had already signed to play at the University of Richmond. And he suffered a hyperdorsiflexion injury, like Joe talked about. It's an axial load to the heel. He actually didn't get to me until about 3 weeks after his injury. And just kind of how these things go sometimes. But he walked in, he was limping, he was in a boot, he wasn't on crutches. He had pain under the plantar plate on the first MPP joint. He had swelling, and there was still some bruising there. And he was very painful with passive and active motion. He had not developed a claw toe deformity, and usually that didn't happen until much later. So these were his x-rays. I normally get bilateral standing x-rays. However, this had been done in the clinic, in our urgent care clinic the day before, and the MRI had already been ordered and done. So I didn't repeat his films, but typically I get bilateral standing x-rays, and you could see that the sesamoids are subtly retracted here, but it's nice to have the contralateral side to be able to compare them when you're looking at them in clinic. And like Dr. Parekh talked about earlier, you can see in the lateral view, you can see that the sesamoids are retracted and they're not concentrically reduced under the first metatarsal head. And then here are 3 good images from the MRI. First is the axial view that shows a complete rupture. And then there's the medial and the lateral sesamoid, where you see no connection between the proximal phalanx and the sesamoid. So it's a complete rupture, grade 3 injury. So talk a little bit about incisions. Dr. Parekh talked about this before. There's a couple different ways you can do this, either with a 2-incision technique or a single incision technique. I had fixed a few of these in fellowship and in practice now about almost 6 years out. You don't see a lot of these. So one I had done before, I used the middle incision as a single incision technique, and really didn't like it that much because it's hard to get over to the other side. And so on this particular athlete, I used the incision on the left side, and that's a lazy J incision that starts a little farther distal over the flexion crease at the IP joint. And I've used that a couple times now and haven't had any nerve problems. And I really like it a lot better as a 1-incision technique if you're going to do a 1-incision, because it allows for a lot better visualization, and it allows you to work around the FHL tendon and get to the sesamoids and the plantar plate injury. But that's my preference, and it worked. It worked just fine in the few times that I've done it, because again, it's not a very common injury. So in the operating room, this was not something that was expected, but something that I prepared for. But interestingly, this was a complete avulsion from the plantar plate, off the plantar plate from the proximal phalanx. So the proximal phalanx was bare. There was no soft tissue attachment there. What little wisps of tendon would not have been able to hold a stitch or affect an effective repair for this injury. So I had to go another route, and I used 2 corkscrew anchors, and I put those in the proximal phalanx at the median and lateral sides of the base. And with this particular corkscrew, there's lots of different ones out there, but basically you can just go ahead and screw it in, or you can pre-drill it with a K-wire. In this particular case, young and healthy athlete, he had pretty good bones. So I used a small K-wire just to create a pilot hole because I didn't want to create a fracture in the bone. And I was able to get really good fixation of this anchor into the bone. So unfortunately, I don't have any intraoperative x-rays, but these are his post-op x-rays. Dr. Park and I were talking about this x-ray earlier. It looks like he's got a partially ossified tibial sesamoid. You'd have to zoom in and look really closely, but his sesamoid is there. It's just, I believe it's disuse osteopenia, but the outline is there if you zoom in on this x-ray. But I was able to get a very good repair using these 2 separate anchors. I had good visualization through that lazy J incision. And this was his immediate post-op film. And you can see the anchor on all 3 of those films there. So I was a little more careful with this guy than Dr. Park was. And maybe that's just because haven't been doing this as long, but I was a little more nervous about letting him move so early. So he was strictly non-weight bearing in a splint with a dorsiflexion block, and he was placed in a slight plantarflexion like Dr. Park talked about earlier. At the 2-week mark, I actually took him out, put him in a cast for 4 weeks. I was just super, super careful with him. And because he was young and healthy, I probably got away with it because he was great about doing his therapy. But I took him out of that at 6 weeks, and he started partial protected weight bearing, and he started moving and got into a out of the shoe and into a Morton's extension a couple weeks after that. But I was only allowing active motion. We transitioned to passive motion, and here you can see the carbon fiber plate that we used. At 2 months, he was in regular shoes with the carbon fiber plate. He was doing active motion, started passive motion to tolerance, but I wasn't letting him doing any running or jogging yet. Again, I was going a little slow with him. And his motion was a little slow to come back, but he definitely got it back. And so at 3 months, he was basically dribbling up and down the court, running, hadn't done really competitive basketball play at the 3-month mark when I saw him. But then I talked to him a couple of weeks later and just told him he could keep going. And he was playing competitive basketball at about 3.5 months out, and was basically asymptomatic at 4 months, which was nice. And these were his 4-month x-rays. And you can see that medial sesamoid a little bit better. The tibial sesamoid a little bit better. So I probably just disuse osteopenia on those initial x-rays. So, he had minimal pain. He was really good about doing his therapy. I personally think you really need to pick your therapist for this. I think this is a rare enough injury and something that has to be really monitored very closely to really insist on them going to somebody you know and trust, or at least somebody you can communicate with a lot. Like I said, at 4 months, he was full return to basketball with no restrictions at all. He enrolled on time at school and started summer workouts and was at full speed, had no pain, no restrictions whatsoever, and was very happy with his outcome, as was his parents and his coach. So it's an interesting presentation there with the complete avulsion, something I hadn't seen before, but it worked out really well.
So that's a great case, Dr. White. Any questions from Selene or from the audience?
None yet.
Very good. All right, I'm going to turn it over to Dr. Jackson.
Outstanding. Perfect. Well, thank you very much, Dr. Parekh, for hosting this. I think it's a great way to provide education to a very diverse group. So thank you very much. And thanks, Dr. Park, for including me. I think this is really spectacular. So I'm going to talk about one case. I'm going to focus on a little bit kind of different aspects of it from what Dr. White did. I think that you've heard several of us say this is a rare injury and no one treats these a lot. And so I think knowing some of the specifics and some of the technical details is really important. So I'm going to give a case as a 21-year-old Division I football athlete. I'm at the University of South Carolina. This was one of our athletes here. They were doing essentially a tackling drill. They were partnering, kind of pushing against each other basically as hard as they could. And he had onset of great toe pain on the left side. He was able to walk, but could not finish practice and came to me. The other thing I would agree with Dr. White about is oftentimes when these are not our athletes that we cover directly, it's often several weeks before when the injury happens and when they get to me, which I think affects the tissue quality as well. So as been previously mentioned, I do get a standing AP. You can see that left side is a bit retracted when compared to the right. Obviously, this patient had an MRI scan as well, which is, at least for me, my go-to imaging modality. These are a few slightly cut. So obviously a T2 sagittal, there's a complete rupture there of the FHB that's off the tibial sesamoid. Here's a T1 cut of that same one, again, showing a complete rupture as well as the retraction there. So the next thing we talk about is what's going to be our surgical tactic for this patient. So again, just to confirm, this is a grade 3 turf toe. For me, pretty much all of these get treated operatively because of the overall good outcomes. And then the potentially devastating outcomes, potentially for a skill position athlete that needs to sprint and cut. So, and again, it's been shown through what Dr. Park mentioned previously, some of the good outcomes that can happen with this. So our goal overall is to repair the FHB tendons. So I actually do this in the prone position. My preferred technique is to use suture anchors. And one of the other main things other than repairing those tendons is protect those plantar digital nerves. They truly run right next to the sesamoid. And so it's really important to protect those. So here's my setup. So what I do is I have the patient's foot off the end of the bed. You'll see their contralateral limb. What I have is a lateral post that my sports partners use for knee arthroscopy. I flex their knee at 90 degrees and I fix that to that lateral post. I actually put a Mayo stand cover over that post just so it's sterile. And then I'll use this extremity drape. So this is what this looks like from the side. This is what it looks like from the end of the table as well. So you can see that lateral post and how we drape that. Obviously, we elevate that bed once we're ready to prep them, or pardon me, once we're ready to do surgery there. So that's my preferred positioning technique, is to do this prone. Then you can do several different approaches, as has been mentioned. For this particular patient, I did an all medial approach in order to be able to fix it. So mainly just fix the medial side. It was the main thing that we fixed for him. I have done the J incision as well. I have not done the 2 incision techniques either. I do either an all medial or a J type of incision. And I think we are all able to get a pretty good repair with that. So we have a couple of, so the next thing I do, and this is actually before prepping and draping. So what I do is actually take a fluoro of their contralateral side and I show that. So here's the side that's working. You'll notice that the sesamoids track there and that's very good. And then here is our injured side. And you'll see there's a preoperative. So clearly the sesamoids are not tracking properly. So that's really a big difference there between their uninjured and their affected side. And I'll play that just one more time. How those sesamoids move there. And I'm not stressing it quite as much on that other side versus on their injured side. So this is what this should look like in a grade 3. And again, to me, this is an operative indication. Some folks have fluoro in their office, and they can do this as an intra-office test to see if they need surgery or not. I do not. Dr. Park, as he mentioned, does a dynamic stress lateral, which I think does a very similar job to this. So here's an intraoperative couple of photos. So one thing I do in the prone position, what's very nice for me is that the toe is sitting there right in front of you. So this patient, I did a J incision on them. The other thing I'll use is a vessel loop. So I don't put anything around the vessel loop. But the very first thing I want to do when I go in there surgically is I want to identify that nerve. Again, it literally runs right next to that plantar plate, and particularly the FHB tendon on the tibial sesamoid side, and right next to that tibial sesamoid. So once I identify that nerve, I try and free it up as completely as I can so it doesn't scar down. And I put a vessel loop around that so I can identify that immediately throughout the entire surgery. Even in this patient, you can see there's pretty clear complete plantar plate rupture. I'm going to show that again through a couple more photos. So that's the retraction. There's the FHL tendon. And then we've retracted that FHL tendon, and we can see all the way to the contralateral side. So my hemostat is on the essentially adjacent to the fibular sesamoid and where that would insert on the proximal phalanx. So we can use that vessel loop for some light retraction, which I'm showing there in both those clinical photographs, as well as, again, that FHL tendon on the left. So this, once we have that suture anchor in position, so I actually prefer to use an all suture anchor as my preferred technique. The benefit to me of an all suture anchor is, one, I don't have to look at it for the rest of my life in the patient's toe, which is great for post-operative radiographs. But really, to me, the actual main benefit is it's a smaller caliber. So typically I use a 1/8 suture anchor, which uses a 1.3 millimeter drill, which is very, very small. It's either 1.3 or 1.5 based on the density of the patient's bone. And so I can drill a very small hole and put in one anchor or two. Currently, I use a double loaded suture anchor. So I drill with generally a 1.3 or 1.5. It's a 1.8 millimeter suture anchor and has 4 sutures attached to it. So then I can advance the tendon. I think, to me, the benefit of the suture anchor is it's very, very strong. It has suture tape on it, as you can see there on that left clinical photograph. So it's very strong. The other thing, particularly if these patients are delayed and they're 2, 3, or 4 weeks out by the time they get to see you and get in the operating room, I believe that this is a very strong and rigid construct, and you can really fix that tissue well, even if you need to go adjacent to the sesamoid. The other thing I would consider doing on more delayed cases is incorporating that abductor hallucis tendon, and I'll incorporate that and advance that as well. And I can do that with the suture anchor, particularly one of the double loaded suture anchors. Sometimes that will just go on one side into the FHB tendon on the tibial sesamoid side, and then that'll go in the abductor hallucis tendon. The key is to not put that through or around your nerve and to protect that throughout the entire procedure. So the clinical photograph on the right is after we've tied that suture. So I've passed it on the left, and then I've tied that suture on the right. You can see that toe is in plantar flexion. When I tie these down, I want these in a maximal plantar flexion of the toe, which I think is much easier to do in the prone position. And the tissues are not fighting you quite as much as in the supine position from my standpoint. So I think they've talked fairly extensively about the post-operative protocol. Mine's very similar to what Dr. Park mentioned. I think the key is doing active plantar flexion after 2 weeks, but no significant passive plantar flexion and no dorsiflexion beyond a neutral position for that first month to even 6 weeks as they're recovering. And then I absolutely keep them in a carbon fiber insert for the first several months after. Generally, I like to get them back to full participation in sports in the carbon fiber insert, and then we slowly wean that out. So hopefully that was helpful with a few of the positioning and technical tips and tricks for repairing a turf toe injury. So thanks, Dr. Parekh, and thanks, Dr. Park, and I'd be happy to answer any questions either now or at the end of the presentation.
Yeah, hey, this is Truitt Cooper. I'm part of this panel. I had a question for you guys. Have you thought at all about, there seems to be maybe a trend, there's not much literature about it, but have you thought at all about simply repairing medially and leaving the lateral side alone?
I definitely have, and I've done that in 2 cases now. And so far, those patients have done well. But I would say that is a level 5 evidence at this point.
Yeah.
Yeah, and I agree. I think in speaking to some of our mentors like Dr. Anderson, I think the important part is to set the tension appropriately. And I think if you can keep the toe in some plantar flexion and let them actively plantar flex, I think you're going to get more robust healing than, if we left it alone and didn't fix it. And I think traumatic bunions, I think are common in this scenario. But yeah, that's a great question. I think maybe the inner sesamoid ligament perhaps allows it to be tensioned properly if you fix a really nice repair immediately.
Hey guys, question from the crowd. At what point do you guys decide that a repair is not going to work? Is there a time frame by which you say, hey, repair is not appropriate? That's the first question. And the second question is, what if you go in and there's no good tissue to work with? What do you guys do?
Maybe I can tackle that. So I actually have a football player who is almost a year out from a turf toe, complete turf toe, was treated non-operatively. And so we're at this point now where we're trying to think about whether to do it sort of in a more chronic situation. I think as Ben mentioned, you can use the abductor hallucis What I've started doing is I've had to do 2 cases like this, but during your medial approach, when you take the capsule down, you can almost like you would excise like a little bit of capsule doing a hallux valgus correction, but I'll take a little downward cut, making a flap, and then I'll use that flap to interpose in between. And normally there's enough tissue. I think you can take some tissue from that medial collateral area. And these chronic cases, they often have a ton of scar tissue. Perhaps Ben can speak to that too, but that's worked very well. So I think in a chronic case, you just have to reinitiate the inflammation process by sometimes cutting through that chronic scar tissue that's formed.
Yeah, I would agree. I think as far as when it's too late, I would consider if a patient has developed like the claw toe, or as Joe said, that intrinsic minus position, if that has started to develop, I don't know at that point it's a salvageable situation because of some of the chronic scarring, even the collateral ligaments that weren't initially injured, but simply because the force and angle of pull has been changed. Even those intrinsic muscles are not pulling properly. So I'd say once they start to get a claw toe, I don't know, at least in my hands, that's a salvageable situation. And in those cases, if you treat them surgically, that could be a career-ending type of thing, because a lot of times that's more of an MTP fusion, I think, if they're to the claw toe. So hopefully we can identify them early beyond them. And as far as other tips and tricks, I think that to me, using suture tape is helpful. Trying to get any collagen available that you can. I think the abductor hyalus is very helpful. I have not used any type of allograft. The other thing that I think can be helpful is to roughen up the proximal phalanx to try to help stimulate some bleeding there. So ultimately, I think if you get enough scar with a good, strong suture anchor repair, I think that can be a very functional repair for a lot of these folks.
Yeah, I would agree. I think especially if it's a fixed claw toe, that's the end game. But a lot of these people will develop some chondral wear and some arthritic changes pretty early on. Maybe it's from their injury, maybe not, but you see them 6 months later, they've already got some chondral wear and they're stiff. And if they're already super stiff, I think trying to fix them doesn't really help them, because even if you make it more stable, give them strength, they don't gain their motion back, and they still have pain. One other point I wanted to make is if you look back at some of the older literature, especially, there's talk about, hallux varus or lateral based injuries being more common. My experience has not been that. And again, this is anecdotal, and I see a fair amount of these where it's sort of plantar and then the medial collateral ligament is disrupted as well. So I always look for that. You're looking right at it. It's easy to fix. I do think there's a role maybe to fix, even if you look at an MRI and there's a complete rupture, medial and lateral, I think there may be a role to fix just the medial side and leave the lateral side alone. I like to get these people moving early. I like passive plantarflexion. I think that's harmless. It doesn't stress the tissues at all, but it gets the MTP joint and the sesamoid complex moving underneath the metatarsal head and prevents some adhesions and arthrofibrosis, perhaps. So I try to initiate that early. Mostly, we're talking about elite athletes, and they have access to trainers and things like that the average citizen doesn't have. So you can explain to them that, it's fine to passively plantar flex them. There's no strain on the tissues with that. No passive dorsiflexion at all. Active dorsiflexion against resistance isometrically is fine. But yeah, so those are some of my thoughts.
Yeah, I agree with all of you guys about the chronic injuries. I think you might just be making somebody different. I don't think you're going to make them any better if you're fixing that injury late. Best that the tissue is going to be pretty bad. So yeah, I wouldn't. I think it's a tragedy if it is a late injury, especially in an athlete like that. But yeah, I don't think there's any point in trying to do that. I think it's just going to be futile.
Great. All right, Truitt, do you want to present your case?
Sorry, is that clear? You guys see me?
Yep, we got it.
Great. So thank you very much, Selene, for hosting this. This is an amazing event. I was talking to one of my ophthalmology colleagues tonight, and telling him about it, and he was amazed and said, "Wow, we should do something like that." So thank you. It's a great event, and we're happy to kick it off. So this is a little bit different case. It's not necessarily an elite athlete, but I think she's a high level athlete. She certainly thinks she is. She's a 58-year-old female who injured her left foot playing tennis. Didn't really recall a specific mechanism, but sudden onset of pain, unable to finish the match. And these were her initial radiographs. So you can see she's got probably a bipartite fibular sesamoid. Overall, it looks pretty good. So what would you guys do with that? She has pain at the MTP joint. It has this injury. I'm inviting my colleagues here to unmute themselves, and we're going to be interactive here. So Joe, Ben, Peter, unmute yourselves. So what do you do here? So you got a 58-year-old female. She's got this X-ray. She's swollen around her MTP joint, really tender there. What would you do for her?
I treat a lot of these non-operatively. I treat her in plantarflexion about 10 to 15 degrees. I like to use Coban just because, and I show them how to apply it. I do start with FHL flexion pretty quickly. I do think it helps them, as you said, just to keep the joint moving. But I would probably not fix this acutely. I think it seems like the diastasis is through the sesamoids. So I would probably try some prolonged immobilization.
I think it's unclear if that's chronic or a fracture,
Correct.
But like, would you get, again, this is a 58-year-old person. Yeah, she's loves to play tennis. She's pretty good, but would you get advanced imaging right away, or would you say, no, we're gonna boot you and see how it goes?
Oh yeah, that's actually a great question. You know this, but I've been doing these ultrasound studies with our radiologist too. I think that's a great image because you can get it in the sagittal plane. If you can see that's diastasing between the sesamoids, again, I don't think fixing the sesamoid is a predictable recovery. And so in this instance, again, I would probably get a dynamic ultrasound to see what it shows and likely treat this non-operatively.
I think, Truitt, I would get a standing AP view first, and then I have almost no hesitation in getting an MRI in these folks straight away, because I want to be sure I know exactly what the problem is. I mean, is that a chronic bipartite sesamoid? Is it acute? Is there some AV into the sesamoid, particularly with no definitive kind of mechanism? Nobody fell on her. It wasn't after one specific thing where it's probably a rupture. So I would want to see, is it sesamoiditis, AV into the sesamoid, a symptomatic bipartite sesamoid, or something more?
Yeah, I think Ben brings up a good point. Just to remind everybody that there was no specific injury with her. This was just, hey, this was hurt.
It was a sudden onset and perhaps an injury, but she couldn't tell me what the injury was.
Okay. Yeah, I'm with. I would not hesitate to get an MRI just to get all the information, because it's been 6 weeks. I don't want to know what's going on anatomically, but also knowing what her, like you said, she thinks she's pretty good and probably is, but hey, look, this could be a bad injury, and go through if it is, and if we don't fix it now, what a fusion would be like down the road. I think we'd have a big conversation about all that stuff right away. But I would probably not be real aggressive about treating her surgically.
Yeah. So what's the oldest person you guys have done an acute turf toe injury repair in?
20.
Yeah, exactly.
22, 25.
Yeah. Right. So she's 58, but nonetheless,
I've done up to mid-30s actually, in a very elite athlete.
So at this point, she was seeing an outside orthopedist initially, and they placed her in a boot, and they did obtain an MRI, and so this was her MRI. So on the left, you can see the medial side. It looks questionable, nothing too bad there. On the lateral side there, you can see complete disruption of her plantar plate, sesamoidal phalangeal ligament, FHB tendon, whatever you want to call it, but complete disruption, more lateral than medial, and some retraction there. These are the T2s, not a ton of edema in the sesamoid. So I think that confirms that it is a bipartite sesamoid, not a transsesamoidal fracture dislocation. But again, medially, pretty well lined up. Maybe a little bit of an injury there, but nothing terrible. It's not a great MRI, but laterally, there's a pretty big gap there, which is not something I see commonly. So does this change your thinking if you saw that and say you're 1 or 2 weeks in on this patient, 58-year-old, what would you do?
To me, if it's one-sided, that's a grade 2 injury, and that's non-operative for me.
Yeah, I would have a hard time making her go through that when, I mean, honestly, you could function pretty well at 58 playing country club tennis with a fusion.
Yeah.
If that's what it came to.
I mean, yeah, no, I don't disagree. Joe, anything different?
No, and I worry about repairing laterally. First of all, it's a terrible approach just going laterally, as I've done that a few times.
Yeah.
But secondly, I worry about pulling on that bipartite sesamoid aggressively, and I worry that you're going to make the problem worse.
Yeah. So she showed up to me about 6 weeks after this injury. That's why it wasn't that painful. She had a little bit of swelling, a little tenderness. And at this point, she did have a little bit of hallux varus clinically. So, what are the options? I talked to her about non-operative and operative treatment. I said, look, if we go and try to repair this, I think the chance of you ending up really stiff and still painful is pretty high. I don't think that you're going to get your full motion back. Why don't we see how this goes? These lateral based injuries, in my experience, I would expect them to do a little bit better. She's not going to develop hallux valgus. She had a little bit of varus, but I could strap her and see how it goes. So she and I talked a lot about it and elected to treat her non-operatively. And so I told her to stay in the boot for about 3 more weeks. We did some toe strapping, pulling the hallux into a little bit of valgus. That's easy to do. You can even put a shoe on and do that. And we'd see how she did. So 4 months after the injury, she had still a little bit of mild hallux varus, but really minimal pain, and she had returned basically to regular shoe wear and tennis activities with not really much limitation. So, I felt like this was a good outcome for her. I knew the jury wasn't out on this, and that maybe it's not done. And so she came back to clinic a year later, and she had worsening deformity, more varus, and she had clawing of the big toe, which surprised me a little bit. If you look at this AP X-ray, you can see that the sesamoids, both of them, are completely retracted. You don't need a great stress view to look at that. You can see it on the lateral view. I mean, they're both completely retracted. There's questionable diastasis in that fibular sesamoid. I don't think so. Her biggest complaint was, she complained about the clawing, but she also had developed a second hammer toe. And I really don't know how to relate that to this. Maybe that would have happened anyway, but that was probably her biggest complaint. But the clawing and the hallux varus was starting to limit her shoe wear. She was still playing tennis, but had a fair amount of pain. And so, what would you guys do at that point?
Hey, Truitt, I've got a quick question for you. It looks like she's got a little subchondral cyst.
Yeah, she does.
Did she have that on the initial MRI scan that you had? Do you recall? No
real arthritic changes at all. It was a pretty healthy looking joint. I don't see any edema in the metatarsal head. If you go back to the original X-ray, it's not there. So that was, a year later, she's already got that. And that's, I think, goes to our point of, like, even in these young people, you see these injuries, if they don't get treated early, if they're severe and they have instability, they get arthritis fast. And so, so what would you do at that point?
You already know, as my partner, I really love the MTP fusion. I think in this case, I tell her about Leighton Hewitt, who used to be a #1 tennis player in the world, and he played his last 2 seasons of ATP tennis with a fused big toe. And I tell them that I definitely can't play like Leighton, and if you can with this fused toe, I'll be very happy with that outcome.
I use the exact same story.
Yeah, and I had talked to her about that the day I met her. She was 6 weeks in at that point, and I said, look, if we try to fix this, I doubt it's going to make a meaningful change in your life. You may get arthritis in this toe, you may get deformity in this toe, but the reality is the treatment's going to be the same whether we do another operation right now and try to fix it, or we wait 6 months and see how you're doing. And so at that point, we straight to a fusion. These are just the initial films. I actually only did this case a few weeks ago. I did fix her hammer toe because that was bothering her as much as anything. But I think it's an interesting case that I didn't expect her to develop so much hallux varus, or so much clawing of the big toe, especially, because really on the MRI, it looked like primarily a laterally based injury, and you just don't expect to see that especially she didn't have it 4 months post-op. It developed late. So
I bet you wish she had done this sooner.
What's that?
I bet you'd wish she had done this sooner.
Well, I don't know. I mean, she still didn't have that much pain in the big toe. She likes to wear fancy shoe wear and things like that. Not high heels, but it was more the deformity, and her biggest complaint was honestly the second hammer toe and irritation of the great toe IP joint. I mean, she's got pretty significant clawing here, and that was really rubbing raw on any of her tennis, not even just heels or anything like that, but any of her tennis shoes that was rubbing. And so, I don't think there's a good fix for that otherwise. And I think that an MTP fusion, bring her proximal phalanx back down into a normal alignment. You can see her. I mean, I think we got pretty good alignment there. I was really careful not to leave her dorsiflex at that first MTP joint. If anything, I would err on the side of too straight. And I've, I don't know your guys' experience. It's unrelated to plantar plate injuries, but I've seen many more people who are too dorsiflex at their MTP fusion than I have that are too plantar flexed. And so, especially with her, deformity, I wanted to make sure, this is a pre-contoured plate, and I wanted to make sure to straighten it a little bit and not dorsiflex her at all.
Yep.
It's a great
but
case.
Sort of an unusual
great case.
Yeah.
You guys-
I mean, wish could have saved her the fusion, but I kind of thought it was inevitable when I first met her, but no reason to rush into it.
So we got a question for all of the faculty members. What do you do in the case of a turf toe that has a sesamoid fracture? Are you fixing the fractures, or are you excising one piece, both pieces?
So I've actually had one of those. I had tibial and fibular bipartite sesamoids with diastasis through both of them. So the injury occurred, it was a plantar plate variant, but it occurred through both. It was an acute high school athlete, and I fixed it, and I basically reduced it and cerclaged it with, I believe it was fiber wire or Ethibond, and just really tightened it down and treated him the same way. And it worked actually really well. He went back to playing. I thought about presenting that case too, but I had never seen one of those before. But yeah, I fixed that in a young guy.
Yeah, I think it depends on where in the sesamoid it is, and if it's one or both. I think if it's a distal pole
This is right in the middle. This is transverse, right in the middle.
I think if it's a distal pole fracture, you're much better off excising that than trying to fix it. I think if it's truly like bipartite or mid waist, maybe you could try to cerclage it. It's my experience in fixing sesamoids is close to zero, because I've avoided it like the plague, because I just think that it doesn't work most of the time.
I didn't put hardware in it. I think that would have been,
I think if I was ever,
I think it would have been impossible.
I don't think I would ever put metal hardware in a sesamoid or a screw.
I never have.
Like that. I don't bone graft them. I tend to, especially if it's one, I'll excise it. If it's both like that, I think I would do what you did and cerclage it with a suture material and see if we can get it that way.
Yeah, that's the only one I've ever done. I had a distal pole a while ago, and I excised that.
Yeah, I have not done one. I think Dr. McBride published, and I think Dr. Anderson had some very, very poor results with trying to fix sesamoids. They put a little teeny tiny screw in them, bone grafted them, and I think they had very poor results with that.
Yeah.
My experience with that, I had an elite gymnast who I did that for, and bone graft. I took some calc bone graft because it was a pretty big defect, and I used a cerclage technique that Dr. White described. And she actually healed it beautifully on a CT, but it actually became hypertrophic. And, she ended up seeing Dr. Anderson upon, my suggestion, but he was like, well, I don't even know how this healed, but she still hurt. And she ended up having the sesamoid excised, and she did great after that. But I think you have to let it scar in. So I think whatever you do, the perfect example of that is Kyrie Irving. The basketball player, he had that exact injury, diastasis through both sesamoids, and he was treated in a cast for 6 weeks. And he, as you guys know, has had a pretty successful basketball career. So in my opinion, I think casting works great. It's never going to look perfect, but I think it's always good to have those examples, anecdotally, of cases that work well with casting.
Yeah, and I do think, we talk a lot about fixing these, and in high level athletes with the grade 3 injury, I would lean towards fixing them, but casting is an option. You just have to, it's honestly almost more work. It's like treating Achilles non-operatively, right? Like it works pretty well, but it's less forgiving if they screw up and they take their boot off and they dorsiflex their foot and slip in the shower, or things like that. So I think you lose a little bit of that with casting, and you got to make sure you're balancing that out. But you can cast people and they can do well, even at high level athletes that are elite skill positions.
Sure, that's exactly where I was going to go to. When you have your high level athletes, the Kyrie Irvings and the other skilled position NFL players who, time is of the essence. How are you guys balancing the time it takes to get back to playing from surgical treatment versus casting and the atrophy and the waiting?
Yeah.
How are you guys balancing that?
Well, for me, I think that's the struggle, and being at a university, we have our sports partners and trainers who are much more aware of this injury. So I tend to see these guys much more early. I often see them a week or two from the injury. So I think I'm a little spoiled, and I try to do these cases a little bit earlier.
Yeah, I think especially if you get to them early, I think fixing them does allow early rehab. You're not in a cast. I think a new sort of a newer idea. The idea of BFR, blood flow restriction training, is like, it's taking over. Every physical therapy office now is emailing me and say, hey, you're okay if I do BFR on this patient? And I think it's great. I think it actually has a great role. I don't know if it's the right thing for everybody, but I don't think it hurts anything. And so, you can do more of that. If you're treating these early, you can, there's a lot of opportunities. So I do think it's more forgiving to treat them early. I think ultimately you could probably get a similar outcome non-operatively to operatively with a lot of these injuries, just like any sports injury. But the rehab is of the essence, and if they're in season, I tell them their season's done anyway. It depends on the timing of where they are, but most of them at this point, I especially in a high level athlete, grade 3s, I tend to treat them operatively. I think the downside is low. I think we can rehab them well sooner. I think if you're careful, you can avoid the complications of nerve injury and things like that. Obviously there's some risk, but I think that honestly, the risk of treating them operatively is probably lower than the risk of treating them non-operatively, in my opinion.
Yeah, I think it's much more predictable from I watch something a whole lot closer that I don't fix than when I do, and it gets them. They want to be back yesterday. And so I think the rules are changed a little bit for high level athletes, and all of us treat high level athletes. I think the earlier the better, and doing a low risk predictable operation that you can trust the repair. And I think it's easier on everybody to do it that way, and they get back soon.
Yeah. I told Joe probably 5 years ago, 7 years ago, we talked about it. And I said, if I have that injury, just treat me non-operatively and I'll be fine. But, I think I've changed my tune. I think I would have it fixed now if it was me. I'm a less high level athlete than I was 5 years ago, and that was pretty low. But I still think I would not be in a cast. I could be in a boot, walking around, doing some stuff, and give it a better chance. So I think that the results, the problem is not the problem. I'm glad, but one of the issues we deal with is that these are not common injuries, and there's no great large studies, and there's no way to do a random. I don't think there's any way to do a randomized study on this at this point. I think it would take a multi-center study to look really at a big enough number to really know how much difference we're making by fixing these, whether you need to fix the lateral side or you can just fix the medial side, whether it matters if you fix them at 1 week or 6 weeks, those kind of things. And we don't have those answers until we kind of are all going on anecdotal evidence of some of our mentors have led the way, and they say, oh, this is what I'm doing now, and it works. I'm like, okay, that sounds great.
And they've done 3 or 4 because it's so uncommon.
Yeah, I think I'd agree with everything everybody said. I think the other two additions I would make is, one, I think this injury is a lot about expectation management. So, I think literature would say it's going to be 4 to 5 months before you get back out there and playing. So just so the coaches, the training staff understand kind of what the recovery is. And then I think this is probably one of the single biggest things from my standpoint, that the the athletic trainer, physical therapist is really, really important in. I can think of few injuries I care more about their therapist and their athletic trainer and the patient all understanding what the restrictions are and what they can and can't do. I think it's really important. I think it's easy to screw up early. Even if you have a very good repair, that tissue is not great. And even if you repair it well, if they do something crazy or fall on it, then that's just not going to do well. So I think teamwork is really important on this one.
Great point.
Yeah, I think this, really quick, I was just going to say that this is an opportunity, with this international community on this meeting, for us to try to collect our cases and do it prospectively. I think this is one of those amazing opportunities. But you're right. Each of us have fixed, I've probably done, 15 or so in 12 years. And that seems like an awful lot, but it's really not enough to give, great prospective data about this.
I've gotten more aggressive. I mean, I think early on in my career, I was very gun shy to operate on these, and I really maximized conservative care. Over time, I've gotten much more aggressive on these athletes, whether they're the weekend warriors or the high level athletes, to fix these, because especially if it's purely soft tissue, I think that they do better just anecdotally with surgical intervention than with a bony injury. I think with the sesamoid fractures, absolutely give the bone a chance to try to heal, but the soft tissues I've gotten aggressive on.
Yeah, absolutely. And my last point would be two things. One is I always look at the medial capsule and be prepared to just reef that, imbricate it, tighten that up, use the abductor hallucis. And secondly, I always tell patients, I really wish they hadn't called it a turf toe injury, because that just sounds so trivial, and it's not trivial injury. I tell them, I was like, if you dislocated your knee or tore all the ligaments in your knee, you wouldn't be surprised that this is a major injury, but just because it's your big toe, you think it's not a big injury, but it's a big injury.
Yeah, I agree with you. It's a big time injury.
Yeah, career ending, right? If not treated properly.
Can be.
Yep.
Even if treated perfectly, it can
Even
be.
if it's treated, yeah, it can be tough.
Perfect. All right. So I think we're coming to a close. I just want to thank one more time again for the Parekh Family Foundation. It's really an honor. And thank you for our faculty for this. This was really an awesome discussion.
Yeah, thanks everybody
thank you,
for
guys.
joining.
Thanks a lot, Jeff.
Thanks Lasso for sponsoring this hour. We will be back in 3 minutes at the 9 p.m. time, New York City time, to start the Jones fracture session. Thanks everybody.
Thank you.